Miriam Shahzad from the University of Toronto, who is going to talk about supporting return to work outcomes among adults with a concussion, the scoping review. Thank you.
Click along with this here. Okay, perfect. Good morning, everyone, and my name is Miriam. Today I'm here to present my scoping review, again titled Supporting Return to Work Outcomes Among Adults with a Concussion, a scoping review. You might notice some overlap in our presentations. This is being completed as part of my doctoral studies at the University of Toronto. So this is just a brief agenda for what I'll be talking about today. It just gives an overview of the outline of the slides. So beginning with the background, I'd like to define some key concepts to start with. I recognize that we're at the 10th annual Concussion Symposium, and so folks will largely be quite familiar with concussion symptoms, but there are just some terms that I'd like to define to ensure we're all speaking the same language as I move through the presentation. So particularly first starting off with symptoms that may impact return to work, I've divided them here into 4 different domains, which include physical, cognitive, psychosocial, and sleep. Now, all of these symptoms may be barriers for return to work for individuals that have experienced a concussion, but I'd like to highlight some that the literature has identified as being related to poor return to work outcomes in particular. So the literature has identified that post-traumatic headaches, the existence of depression and anxiety, both pre-existing as well as following concussion, as well as sleep disturbance are related to poor return to outcomes in this population. Return to work outcomes. So occupational disability or work disability, what is that? So this occurs when a person is deemed incapable of work, either temporarily or permanently due to an illness or an injury. In this case, we're speaking about concussion, but this can be as a result of neurological, psychological, and physical concerns. Now, in Canada, benefits are largely funded by private insurers for individuals that are experiencing work or occupational disability. Now, these private insurers may be short-term or long-term disability benefit companies, or as we know, workers' compensation boards, and in Ontario, our board is referred to as the WSIB. So we see worldwide an increase in benefit recipients for workplace disability. And so this has resulted in more stringent disability criteria that are largely informed by biomedical approaches. And so often we see that disability insurers require objective measurable evidence for an injury. And as we reviewed the concussion symptoms previously, sometimes they can fall within the domains of psychosocial or sleep. And so something like irritability is quite hard to capture when we're speaking of disability criteria. Now, what do these benefits actually look like? They can include loss of earnings, which is to replace any income that's lost while someone's off work, rehabilitation, for example, physiotherapy or interdisciplinary care in the community, as well as personal care. So the cost of someone coming into the home to support an individual with daily tasks. Now, these are some of the professionals that might be involved in occupational rehabilitation, which is the process of supporting someone to return to work. So I myself am an occupational therapist, and I've worked around 5 years in this clinical setting. And again, we're addressing any of the concerns and the domains that might come up as barriers for return to work. So the return to work context, the return to work process and outcomes are influenced largely by various different parties or stakeholders. Now, what I see and have observed in the literature is largely there's a focus on the injured person, particularly biological factors. So we see that social or psychological factors might be overlooked in the literature and as well as clinical practice. Some other variables as well, such as workplace factors, rehabilitation factors, and funder level factors might also be overlooked within the return to work process. So I've provided some examples of what these factors might be. For example, organizational policies and practices within the workplace, whether or not someone is able to get accommodations, rehabilitation factors, so access to care, what that care looks like, and the funder. So the particular funder might also influence or dictate the return to work process or context. And again, these are largely overlooked in the literature as well as in clinical practice. So what does the literature say? We see that although the rate of injuries are reducing generally overall. The WSIB, we're getting better with workplace health and safety. Concussions are on the rise. We also see that a failure to return to work or prolonged occupational disability can have significant consequences for individuals. So reduced quality of life is an example. And even in individuals who do return to work after a concussion, there's often a degree of productivity loss. So the question that I'm really interested in answering is, what are the critical elements that influence return to work outcomes for individuals? So the literature has identified a few. Largely it characterizes premorbid characteristics that are involved in poor functional outcomes or related to poor functional outcomes. So these are in the form of both primary and knowledge synthesis studies, and I have some examples on the right on my side here. So for example, older age and female sex might be involved in poor functional outcomes. Now the utility is that they can help us determine probable recovery and facilitate appropriate care pathways for our clients. However, these factors are largely non-modifiable in the return to work process. Again, we see the literature in the form of primary knowledge synthesis studies characterizes injury characteristics or biological characteristics that are related to poor functional outcomes or recovery outcomes. And again, this can help us facilitate appropriate care pathways and treatments. And some examples of these might be the mechanism or severity of an injury, largely unmodifiable or non-modifiable, just like the premorbid characteristics covered previously. Now, other factors that might be involved in return to work, we see some primary studies characterizing employer level, rehabilitation level, or funder related factors. However, there's no existing knowledge synthesis in this area. So I've included some examples of what these studies have shown, but this is largely the basis of my scoping review, so I'll discuss this more in the results section. So the research gap really that we're identifying here is that largely there's a focus on pediatric and sports-related concussions when it comes to best practices. So we'd like to focus in on adult concussions. Our study would like to use a biopsychosocial perspective that looks at the role of the rehabilitation team, the funder, as well as the workplace. And finally, we're conducting a scoping review to really explore return to work as our specific functional outcome following a concussion. So the methods that we used scoping review methodology using guidance from our colleagues, Arxine O'Malley, Levac et al., as well as the PRISMA checklist. Our first step was to identify the research question, which is what are the facilitators of and barriers to return to work in adults with concussion as captured in the literature. Our second step was to identify relevant studies. So we searched the following databases, and our key concepts were concussion and return to work. There were no limitations in time span, and we searched English language articles. Stage 3 was study selection using the following inclusion and exclusion criteria. And we had 2 researchers involved in conducting level 1 and level 2 screens, and a third involved if there were any conflicts. So stage 4 is where we're currently at. We're charting the data. So we've created an Excel form in order to chart the data with the input of my supervisor. And 2 researchers have been involved in extracting data from 10 articles independently, and we'll continue with the remaining articles as we go. And we're using a qualitative content analysis approach. Stage 5 is to collate, summarize, and report the results. So in 3 different steps, we'll complete an analysis, we'll report the results, and then consider the implications of our findings. And stage 6 is our consultation. So the purpose of this is really to obtain additional viewpoints. We currently have 3 community partners and contacts prepared that have lived experience with brain injury. And we have 3 community partners that have experience providing occupational rehabilitation in this area that we plan to consult with. So our preliminary results or findings. So we were able to identify 1,082 articles and an additional 18 from hand searching. We then removed duplicates and were left with 592 articles. Following level 1 screens, we were left with 54 articles. And then following level 2 screens, we were left with 28 in our final study. So generally the study characteristics, the time ranged from 1999 to 2022. They were all peer-reviewed articles, primarily qualitative in nature. And the majority of the studies were conducted in North America, as well as some in New Zealand and Australia. Because of our criteria of looking at adults with concussion, we did identify articles that included individuals over the age of 18, and they were all published in 25 different peer-reviewed journals. So our preliminary results have been divided into facilitators and barriers with sub-themes in the areas of the injured person, workplace, rehabilitation, and funder factors. So our results show that within the injured person, committing to the decision of returning to work is a facilitator to return to work. So if you're familiar with the stages of change, someone that's in the action stage of change, being present at the workplace is also a facilitator. So having some on-site coaching or support, adequate rest and having a balance between work and rest, as well as social support for both companionship and help with daily tasks. On the workplace level, facilitators included having some sort of supported employment or accommodations, such as sick leave or modified work schedule, as well as being seen and valued by the workplace, having a nurturing workplace environment and supportive coworkers socially. Rehabilitation related factors included having access to medical and rehabilitation services early, and those services being individualized to the actual person, as well as having individualized education. And then finally, multidisciplinary care. Again, this would be, as you say, the Tesla of rehabilitation, which means that we might not be able to offer it to all of our clients, but what the literature shows would really support return to work outcomes. And then finally, funder level facilitators. So far, we've only identified one, which is having a funder that validates and acknowledges symptoms. The barriers that we identified included within the level of the injured person, total number of symptoms being reported, lack of support within social groups. Within the workplace, having a high workload. Interestingly enough, traditionally masculine work environments were seen as a barrier for return to work in some studies. Poor coworker relations, lack of workplace accommodations or supportive employment. Rehabilitation level factors included poor education or follow-up care, recommendation for prolonged rest, misdiagnosis or lack of diagnosis, poor availability of particularly mental health resources, and follow-up assessments that were too frequent. And finally, on the funder level, lack of support, claim dismissal, little communication, difficulty with paperwork, unclear processes and procedures, and also ones that weren't accommodated for the needs of someone with a concussion, stigma or discrimination, and having representatives that had inadequate understanding of MTBI or concussion. So really just to provide a quick conclusion, there's practice, policy, and literature level implications for this study here. We've identified some limitations. One might be that our study was a little bit too precise because of timeline and resource constraints. And we also excluded military concussion studies because we found that largely the mechanism was blast-related injuries, and those might not be generalizable to the population here that we're looking at. And finally, some opportunities for future research include synthesizing best practice guidelines for adults with concussion and return to work, additional primary studies looking at other stakeholder perspectives, such as the employer, funder, rehabilitation professional, and research examining persistent concussions more specifically. Thank you very much.
Big talk, and I just want to, I forgot to introduce you as you're a first year PhD student at the Rehab Sciences Institute, University of Toronto, and an occupational therapist that has expertise in addressing cognitive, physical, and psychosocial needs of clients with persisting symptoms. Sorry about that. Thank you for a great talk. Well, since I'm up here, I'm going to ask you the first question. So, you know, in other areas, what we've realized is that when we're doing these systematic analyses, these meta-analyses, these scoping reviews, is that the literature is filled with bias of the people who end up in these studies. And I was wondering if you were trying to address this in any way, or you found that no, this is not a real issue, because there are, you know, barriers to even getting into study. We know that socioeconomic status can you know, interfere or be a barrier for being part of research, but you know, cultural differences also and kinds of things.
Yeah, absolutely. Thank you very much for that question. I'm going to do my best to answer that. So at this stage, conducting a preliminary scoping review, we're really just looking to see what data exists As you saw, we found 28 total articles. I think it would be interesting to further then go on and do a higher level knowledge synthesis, like a systematic review where we are looking at the quality of the evidence as well and really evaluating what kind of populations were included or potentially excluded from the study as well. And I definitely agree with your point in that there are barriers to participate in research, particularly for our clients who might have persistent concussions or lower socioeconomic status, or lack of access to facilities that are affiliated with hospitals or research institutions. So I think my plan eventually, as part of my doctoral work, is actually to conduct some primary studies in these areas and work more so with community-based clinics that can be more diverse in terms of the populations they serve.
Next question. Was interested in the masculine workplace finding as a barrier, and no disrespect to anybody here. And but I was wondering if you found a sex difference. Was it women that were finding a masculine workplace more aversive, or everybody?
Everybody. So there were two studies that were actually looking at gender differences in experiences of return to work. And both studies cited that having a more masculine work environment, and this was both individuals that identified as male and female, talking about the social construct of gender. They found that having a more masculine workplace environment was a barrier. And the way that masculinity was defined in these articles was looking at a place that wasn't nurturing or allowing for individuals to have space to speak about their symptoms or seek those resources. So although it was defined as masculinity generically in those articles, there may be a better term to identify that.
Yeah, agreed.
Yeah.
Maybe even fair.
Yeah, I agree.
It's really interesting result.
Yeah, no, thank you. And yeah, that was just the language that was used in the article, but I agree that there may be a better way to frame that.
Thanks. Great talk.
Thank you very much.